Hello, good afternoon, and welcome to today's webinar. Thank you for joining us. My name is Sarah Muller-Robbins, and I am the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled Back to Vaccinate, COVID-19, Pregnancy and Breastfeeding. I would like to review some information before we get started. The planners and speakers do not have any financial disclosures to make. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. To receive a certificate of completion, including 1 nursing contact hour, you must log in, listen to the entire webinar, and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the Partnership's website and YouTube channel no later than December 7th, 2023. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box and the speaker will respond to as many as possible at the conclusion of the presentation. Now I would like to introduce today's speaker. Dr. Rose St. Fleur is a medical director of the Center for Breastfeeding and Pediatric Hospitalist at Hackensack Meridian Jersey Shore University Medical Center. She's a clinical associate professor at Hackensack Meridian School of Medicine and serves as the abstract committee chair of the Academy of Breastfeeding Medicine and the chief chapter breastfeeding coordinator for American Academy of Pediatrics. Welcome, Dr. St. Fleur.
Thank you. Thank you so much for the kind introduction. Hello, everybody. So I am going to be talking about COVID-19, pregnancy and breastfeeding. Oh boy, this information has been changing so quickly. It's really hard to even, keep a presentation that is updated. But this is, to the best of my ability, the most updated information that we have on COVID-19, pregnancy, and breastfeeding. And I welcome a robust discussion at the end of this talk, and thank you so much for having me. Okay, so I don't have any disclosures. Again, I am the medical director for the Center for Breastfeeding. I do participate with the American Academy of Pediatrics as well as the Academy of Breastfeeding Medicine, but these are volunteer member affiliations, and I am not compensated any additional salary beyond my salary as an employee of Jersey Shore Medical Center and Hackensack Meridian Consortium, as well as the Seton Hall School of Medicine. I just have one base salary, so I don't have any disclosures. And this is just another slide, again, addressing disclosures. I have no financial disclosures, as I said. So let's get started. So we're going to really just talk about 3 things, but it's going to be quite a bit of information. We're going to talk about what the current literature is on what we know about COVID-19 disease and pregnancy and breastfeeding. We're going to discuss COVID-19 vaccination in the setting of pregnancy and breastfeeding, which is an oftentimes overlooked and critical area regarding vaccination research as it pertains to pregnancy and breastfeeding. And we'll reflect on the impact of COVID-19 on maternal mental health. So let's start off with a case study. So patient JS is a 19-year-old who presents for a telemedicine visit in March of 2020, which, as we all recall, was the beginning of when the pandemic really began, when we began to quarantine for lactation problems. So she explains that there is a lump in her breast that is tender and painful to touch. She denies fever. She was seen by her OB via telemedicine for 2 visits and was treated twice with antibiotics for 11 days collectively with no improvement, and then she was told to go to the ER. When she arrived in the ER, she did have a fever, which was documented. They did an ultrasound which demonstrated a large abscess that occupied nearly half her breast. She was taken to the OR, was drained, was packed, and she spent 2 days in the hospital. And then she was told to stop breastfeeding completely, which was something she did not want to do, but eventually she did stop doing. So let's just kind of reflect on this case and some of the things that went right, maybe some of the things that went wrong, and then we can discuss this case again at the end of the presentation. So COVID-19 continues to rage on as a pandemic. As of November 30th, We have had 261 million confirmed cases with 5 million, close to 6 million deaths worldwide. In the US, we have had 48 million cases with 776 deaths reported throughout the United States. The CDC does have an examination of what they're calling excess deaths related to COVID, which means that if we were not in a pandemic, we would assume that this individual who passed from COVID would not have passed because COVID would not have existed. So an excess death since February of 2020 is 889,000. And I should mention, some of these statistics lag, some lag more behind the others. So you do see some of these discrepancies here with the excess deaths exceeding the confirmed deaths, because there is a time period that takes place in order for the CDC to decide definitively that a death was related to COVID. In New Jersey, confirmed cases and deaths are 1.2 million and 28,000. And then for vaccinations, we have 196 million people in the country, adults and children, who have been vaccinated. In the US population with a third dose, there's 40 million who have had a third dose. And so for those who are considered fully vaccinated, and the CDC still defines fully vaccinated as having had 2 doses, they haven't considered that third dose in there yet, is about 59%, which is actually quite good. In New Jersey, we're even higher, which is excellent. We've got 6 million people vaccinated in New Jersey, and the percentage of those who are fully vaccinated is 67%. So we're close to that 70% benchmark that everybody, was referencing before, although we don't really know whether or not 70% is really an appropriate benchmark anymore, considering new variants and how peaks and valleys have taken place with COVID. But still, that benchmark, if we're still using that as an adequate benchmark, we're close to it. So it does mean something. So as of November 27th, we're seeing that the majority of cases related to COVID are from the Delta variant. Obviously, this is going to change, and it probably has since I put this slide in this presentation. But right now, or as of Thanksgiving, the Delta variant accounted, as you can see here, for close to 100% of cases. And we know that the Delta variant is the more contagious variant. It is the one that is more easily spread. It is largely and overwhelmingly responsible for some of the peaks that we have had in the last couple of weeks. And we know, like I said, that the Delta variant can cause as many as twice as many infections as what the original strains and the older strains did. And after Delta became the most common variant, fully vaccinated people for which the Delta variant for which the vaccine is quite effective against the Delta variant, fully vaccinated people had a reduced risk of infection by 5 times, hospitalization by more than 10 times, and death by more than 10 times. So we did learn pretty quickly that the Delta variant is more contagious. It spreads more quickly. It's not necessarily deadlier, but it is deadlier by virtue of the fact that it spreads more quickly. But the vaccination, and in particular, if you're fully vaccinated, was very effective against the Delta variant. So you can see here again, unvaccinated people had a 6.1 times greater risk of acquiring COVID-19 and an 11 times risk of dying from COVID-19. And this is really absolutely true. As somebody who works in the hospital setting every single day, overwhelmingly the people that are coming in, adults and children with COVID-19 disease, are largely unvaccinated. Nearly all of them are unvaccinated. Approximately, and this is a rough estimate here because the numbers go up and down, about 5% of people in the adult world are vaccinated who are coming in who are ill, and oftentimes those are people who have many comorbid conditions existing at the same time. So people who are already quite sick and then who are now coming in ill even though they are fully vaccinated. And we haven't really seen any cases of a fully vaccinated child coming in ill with COVID-19 disease. So when you look here at the National Summary of Vaccinations by Race and Ethnicity, you can see here that there's quite a few variants here. The top two tables are looking at 1 dose and fully vaccinated, which again is 2 doses. And you can see here that, of course, the numbers rose as vaccinations became more available, and the numbers rose at varying rates. So the red number in the top 2 graphs, the top left to the top right graph, represents the American Indian and Indigenous population, Alaska Native population. And then all the way at the bottom, the green line represents the African American, non-Hispanic population. And so what you probably are seeing in your communities is very, very much so true, that African Americans are less likely to be vaccinated against COVID-19 for a variety of reasons that I'm sure that you've seen reported in the media and the news. Although I think really, you know, the reasons why people of African American descent, non-Hispanic descent, the reasons why they choose to not get vaccinated is quite varied. But there are lower rates of vaccination in this population. And then when you look at the bottom two, you can see, of course, no surprise that older people are more likely to be vaccinated, in part because of how the rollout and how the push to vaccinate occurred, and younger people are least likely to be vaccinated. I would say that these tables, of course, are going to change. You know, part of the reason why younger people are less vaccinated is because we didn't have that vaccine available. As that vaccine becomes more available for EUA use, these numbers are going to change quite dramatically. And so it's really interesting to note that even though American Indians and Alaska Natives are most likely to get vaccinated, unfortunately, because comorbid conditions are so rampant in these communities, they still have higher likelihoods of being hospitalized. And so as you can see at the table here on the left, American Indians and Alaska Natives are more likely to be hospitalized due to COVID-19 related illness, followed by the Black population, non-Hispanic Blacks, and then followed by Hispanic and Latinx populations. And so this still is the case. These numbers have been around for quite some time and they still haven't changed, that the likelihood of having hospitalization and death if you are an African American person, if you're a Hispanic person, or if you're an American Indian or Alaska Native person goes up anywhere from 2 to 3-fold for hospitalization and from about 2 to 2.5 fold for death. And we think that this is largely, well, in part because for the African American population, because of lower rates of vaccination, but also really for all 3 of these populations, Hispanic, African American, and American Indian, Alaska Native, it's because the risk of comorbidity is so much higher in these populations. So I have some information here on the Omicron variant. Oh boy, the Omicron variant, there's not that much that we know about it. This information changes. And in fact, you know, if I had to do this presentation today, I would have still more to add. But the official name of the Omicron variant is B.1.1.529. Now, it should be noted that the coronavirus, COVID-19 virus, from the very first time that it was identified around December of 2020, January of 2021, has mutated several times all this time, right? So we do know that there were about 4 to 5 different variants that had already sort of swept through to the United States and kind of come and gone. And of all of those variants, previous to the Omicron variant, the Delta variant was the one that was of highest concern. And we, of course, as we see, you know, the fallout to the Delta variant, what we feared was exactly what happened. We were worried it was going to be more contagious. We were worried that because it was more contagious, it would be more deadly, and we were right. And so the WHO, the World Health Organization, is definitely keeping a close eye on mutations going forward. And this was the first mutation since the Delta variant going forward that was what they're calling a variant of concern. So it was first identified in South Africa, November 9th. It was reported to the World Health Organization right before Thanksgiving, and then the World Health Organization then spread that information to all of the other public health organizations, including the US CDC, on November 26th. It's identified as a variant of concern, which by the WHO is defined as a variant for which there is an increase in transmissibility or a potential detrimental change in COVID-19 epidemiology, which is essentially what we saw with the Delta variant. Increase in virulence or change change in clinical disease presentation, which is essentially what we saw with Delta, and a decrease in effectiveness of public health and social measures or available diagnostics, vaccines, and therapeutics. And if I had to add one more bullet to this, this is unfortunately what we're worried will happen with the Omicron variant, is that the vaccine as they exist today, even for double and possibly even for triple vaccinated people, may not be as effective against the Omicron variant the way that we learned that it was effective against the Delta variant. However, it seems to be that the Omicron variant is not as virulent as the Delta variant was. And so we're hoping that even if you do happen to get COVID-19 in the setting of double or triple vaccination, that it will not land you in the hospital, that it will hopefully be mild to moderate disease where you can stay home and quarantine, and then it will sort of be the end of it. But of course, there's still a lot more information that we still need to know about the Omicron variant. There really is essentially no information that we know of as it relates to Omicron pregnancy and breastfeeding. There hasn't been really any information out on that yet, nor is there any information out on Omicron variant for children, for newborns and for children. And so this was the best I could find. This is not scientific data. This was data that was collected by a news organization, Al Jazeera, which is a Middle Eastern news organization. And it showed at the time, this was as of November 30th, the countries where the Omicron variant was identified. You can see that, of course, the orange countries are the countries where Omicron was identified. The US was not highlighted then. It is highlighted now, as we know. I believe the last I read, there are, I think, 7 or 8 cases nationwide of the Omicron variant that we know of. There is, I believe, there's definitely one case that we found in New Jersey that was discovered just a few days ago on December 3rd. And I think that there was another case that was identified also over the weekend or on Monday. So this is rapidly changing data right here. Okay, so let's kind of go back and just talk about what we know about COVID-19 during pregnancy. So we've had a whole year and a half to really study COVID-19 and how it affects pregnancy. And there's certain things that we kind of pretty much know for sure. So we know that affected pregnant women compared to non-pregnant women are essentially worse in several categories. So if you are pregnant and you have COVID-19 disease, your likelihood of developing acute respiratory distress syndrome, which is unfortunately the syndrome that ultimately kills pregnant women related to COVID, increases. So that's a significant risk ratio or increased odds of 34.4, which is quite high. So should be no surprise, likelihood of death also goes up 17-fold. Likelihood of sepsis goes up 13-fold. The need for mechanical ventilation goes up 12-fold. Shock and intensive care admission goes up 5-fold and 3-fold. Risk for acute renal failure, thromboembolic disease goes up 3-fold and 2-fold. Risk of an adverse cardiac outcome goes up 2-fold. And risk of preterm labor along with preterm delivery also goes up 1.5-fold. So you really don't want to get COVID if you're pregnant. You know, you're going to end up, good chance you're going to end up with adverse outcomes. You're going to be more likely to be sick. You're going to be more likely to be hospitalized. And then when we move on to the neonate, what's the risk of transmitting COVID-19 in the neonate? In the perinatal period, a lot of attention was focused on this. You know, well, will I be able to pass it to my baby? Will a pregnant mother be able to pass it on to her child? And so we do know a good amount of data for that. So a couple of things we know. We know that rooming in does not increase the risk of neonatal acquisition of COVID-19, and it is so important to make sure that that is stated explicitly. Because at the beginning of the pandemic, you know, me coming from a pediatric perspective, the very, very first reaction to the pandemic, once it came out and once it became clear that everyone needed to stay home and we needed to quarantine and social distance and all of that, was we've literally have to social distance everybody, including mothers and their babies. But we do now know that rooming in does not increase risk of neonatal acquisition of COVID-19. So we do not need to separate mothers and babies if you have a mother that is ill with COVID-19, with the exception of the setting where the mother is unable to care for her child because she herself is too ill. And if she is too ill and she cannot care for her child, then of course in those settings, a separation is important and warranted so that another caregiver can then care for the baby. But if the mother feels well enough to care for her child, she can go ahead and care for her child with a mask on, and the mother and the baby can continue rooming in immediately after delivery. So there have been many single case studies that have been published because as we were all aware, much of the research that was coming down and trickling into the medical journals on COVID-19 was sort of almost as I like to call it, a catch as catch can. Like whatever people found, they just kind of threw it in there. They just submitted it to these medical journals, and the medical journals were accepting them and sort of gobbling it all up because we didn't have anything. So there were many single case studies that were published which suggested the possibility of acquisition of COVID-19 related to rooming in, but really the larger observational studies showed no direct evidence of transmission. The biggest piece of evidence that we have is from the National Registry for Surveillance and Epidemiology of Perinatal COVID-19 infection. It is a full nationwide registry that reports, supposed to, or is attempting to report every known case of perinatal COVID-19 that we know of. And so from that data, we know that COVID-19 in neonates born to affected mothers were the same, whether the mother chose to room in or whether the mother did not choose to room in. And I should correct that because it was not always a choice made by the mother, whether the hospital elected to room in that patient or whether the hospital elected to separate the patient. As of July 2021, this was based on a collection of 10,000 dyads. That number is significantly higher now, but the average infectivity rate was at the time and continues to be about 2.3% in terms of newborns who are tested positive for COVID-19 in the setting of a mother who also had COVID-19. And I want to be careful when I use that word infectivity, because infectivity does not necessarily mean that the baby is infected because of exposure to the mother. Infectivity simply means that the baby tested positive for COVID-19. We don't know where that baby got COVID-19. We don't know if that baby even got COVID-19 from the mother. We just know that that baby happens to be positive for COVID-19. And the American Academy of Pediatrics still does say that if you have a mother who is positive for COVID-19 during delivery, the baby should get tested whether there's symptoms or not. So we have that information there. It's really a screen in order to collect data, and this is ongoing, but this is what we know so far, that of newborns that have COVID-19, it's about 2%, really a little bit more, about 2.3% or so. So a study that was done by Grove in September of 2020 this was kind of the first big study that really, I can't even say big, but I should say more like a study that got the attention of various media news outlets and many physicians all throughout the country. Definitely got the attention of many neonatologists, pediatricians, and OBGYNs. This was a study that was done out of Germany that really did a serious attempt to look to see whether or not COVID-19 was present in breast milk from an infected mother. Now, before this, there had been a sampling of case studies, about 3, where there was a suggestion that COVID-19 could possibly be pregnant, could possibly be available in mothers who just delivered and who were breastfeeding. However, the studies were really poor quality. For example, in one of the studies, what they did to try to see if there was COVID-19 in human breast milk was they simply swabbed the mother's nipple, which is really not the way that you want to look for COVID-19 in breast milk. But what these guys did was they looked at two mother-baby dyads. And you can see in the table to the right here, one mother was ill with COVID-19 symptoms, and then several days later, the baby was ill with COVID-19 symptoms. I'm looking at the top gray line here. And then the second gray line directly under that, you can see that there's a bracket where it says mild COVID-19 symptoms. The mother had it about 4 days or so, pretty much at the tail end of her hospitalization. And then the baby was asymptomatic, but did swab positive and had symptoms several days later. And then when they tested this the actual breast milk of the mother, they did not find COVID in the breast milk of the mother, but they did have a symptomatic baby, and they essentially concluded that maybe this baby acquired COVID from the mother, and that's why the baby was symptomatic. Second set was a mother-baby dyad. Again, the mother admitted, was discharged. She had COVID symptoms several days later. The baby was admitted, discharged, and then went back to the hospital and ended up in neonatal ICU. The baby had icterus, the baby had breathing problems, and the baby was hypoxic. And when they tested this mother's breast milk for COVID, they did in fact find evidence of COVID-19 virus in the mother's breast milk. Now, this was the mother, both mothers pumped, right? And then they applied, delivered the breast milk into the bottle and then handed the bottle to a scientist who then just simply swabbed the breast milk for COVID-19 and then found that it was there. So what they concluded based on this data was that the second newborn in particular, the newborn who ended up in the ICU, right? So this second newborn, there was a chance that the second newborn could have had COVID-19 from infected breast milk because the mother was feeding the baby pumped breast milk and then the baby became ill. So this research sort of kind of shook up everything. This was around the time when there was some anecdotal evidence emerging that perhaps rooming in was not connected to COVID-19 transmissibility. You know, a little bit of more comfort with allowing mothers to breastfeed their babies because, of course, that was also halted in the beginning of the pandemic since we didn't know whether or not COVID-19 could be transmitted through breast milk. The assumption was to assume that it was and to tell mothers to not breastfeed until we had more research. So that had been going on. And then we were just sort of slowly circling around because, you know, the pandemic started really affecting us around March of 2020. This research came out in September. So we had a whole summer, we had a little bit more research, we certainly had a lot of experience and anecdotal evidence, and then this came out and that kind of put everything right back to where we started with many hospitals and many providers saying, well, based on these two case series, we should not recommend COVID-19 positive moms to breastfeed their babies. Unfortunately, the information that did not come out from this research was that this second baby who had icterus breathing problems and low oxygen also tested positive for RSV. It's really interesting that this was not really mentioned in the conclusion from these German scientists, but it's pretty obvious that RSV can absolutely cause breathing problems, hypoxia. RSV can cause apnea. It's a very well-researched virus. They really did not go into details as to whether or not the RSV could potentially have been the cause of this patient's symptoms and not the breast milk that had COVID-19 found in it. This was really not investigated or examined, nor was it really publicized very much. So it just kind of was left out there and people made a lot of diagnostic decisions based on this research. The good news is that we have a lot more information since that one research study, and we know a lot more things about COVID-19 and breastfeeding and breast milk. So around this time, this study didn't get quite as much attention, but it was there. You know, in July 2020, there was a study that came out of China which showed that there were IgG and IgA antibodies found in the breast milk of COVID-19 affected mothers. This was in a single case study. And then with this study, the breastfeeding infant was found to also have IgG antibodies despite no documented acquisition of COVID. So this was a situation where mother tested positive, baby tested negative, but baby had antibodies. But these dropped right after, pretty quickly after delivery, but they were still nonetheless there. And so based on this information, they concluded that the IgG and IgA antibodies that were detected in breast milk may indicate a potential immune protection for the neonate. And this study was the first study that didn't really look at the virus so much as it looked at the antibodies. They found that there were antibodies in the breast milk. They found out that the baby somehow got the antibodies, right? And this was a breastfeeding infant. And so they concluded, well, you know, could it be that, you know, rather than us looking at breast milk as being the transmissible vector, could breast milk be the protector? Because if there's antibodies in human breast milk, it's got to be there for a reason. If it's there for a reason, does that mean that it's actually operative antibodies that actually work and do something to protect the baby? So looking at this table, these tables here on the right, you can see that they collected the IgG antibodies from maternal serum and maternal breast milk The second table, or the middle table here, has a very tall, sort of darker gray rectangle all the way at the end of the table, and you can see that there was a significant spike in SARS-2 specific IgG antibody titers occurring about a month after this mother delivered and was breastfeeding her baby. And you can see that in the table all the way to the right, that the baby initially had very high IgG antibody titers in his serum, but then at the time that the mother had very high antibody titers in her breast milk, the baby dropped off on antibody titers in his serum. So why it's sort of the discrepancy there, that we don't know, but at least we know from this study that the antibodies are there in the breast milk and the antibodies are there in the baby. And so moving on, this was another study that was also done in 2020. And as these studies are conducted, you know, these numbers are getting bigger and bigger. So this was looking at 44 breast milk samples of from 16 COVID-19 affected mothers for whom they were tested. Their breast milk was collected over the course of 70 days. And you can see that none of them tested positive for PCR. So like in the earlier German study, what they did is they just simply sort of stuck the swab in the breast milk and they found that it was COVID-19 positive. This time, none of the breast milk samples were found to have COVID-19. None of them, but 38% of them, 38 samples did not have IgG, but 21 samples did have IgM. And you can see here the red circles represent IgM, the blue triangles represent IgG, the red and the blue dotted lines represent the relative value of antibody, which is essentially an arbitrary cutoff for which when we say that something is positive for antibodies, then it's because the level of antibody was detected to be above this level. It's just really essentially an arbitrary cutoff. But at least looking at this arbitrary cutoff, we did see that in multiple cases and over the course of almost a full 70 days, there was a significant number of IgM, not so much IgG, but there was some IgM that was found in the breast milk samples of these patients. And so what it added to the body of research that we had was, again, here's another research study that shows that there are antibodies in COVID-19 affected mothers' breast milk. They're there. This particular study showed that they weren't just there from the beginning, but they were there for a certain period of time, at least through 70 days. And for some moms, they were quite high. For some moms, not really so high, and it wasn't really clear, and we still don't know exactly why that is, but something is there and something is happening. So, you know, at least we had that body of research to show that COVID-19 has the potential to have SARS-specific antibodies existing in its breast milk, not just in one case study, but in this setting, in 44 breast milk samples. And then moving on, so what they did was the next step was they wanted to not just continue to look at these antibodies, but they wanted to see, do these antibodies have neutralizing effects? And that's really critically important because just because you have an antibody just floating around in breast milk or in blood doesn't necessarily mean that that antibody is doing the job it's supposed to do. The job that it's supposed to do is it's supposed to attack the virus and neutralize the infectivity of the virus just like the vaccine does. But we didn't really have that information until this particular research study as to whether or not that was actually happening. So in January of 2021, PACE had looked at some samples of 18 COVID-19 affected women. And this was really the first study to show that they did find some antibodies. In this case, they were looking at IgA antibodies. They did find some antibodies, and they also found that those antibodies had the potential to neutralize SARS in vitro. So not in vivo, but they were at least able to identify neutralization in vitro. So looking at the table here, the top right table that just has the red circles here, you can see that in a variety in the variety of samples that they had, that there was microneutralization titers that took place. In the second table here, each color represents a different breast milk sample, and it shows again that there is there is presence of IgA antibodies, and the table on the bottom left shows the microneutralization of those antibodies. You can see that in some women, there's a lot of microneutralization, so whoever was the woman represented by the turquoise line, for example, and the green line over a little bit over to the rest. Some had pretty robust neutralization effects, and some kind of had okay neutralization effects, and some were a little bit more level and weren't quite as high. So it was a bit all over the place, but it did nonetheless show that the potential for neutralization was absolutely there. And the ability for neutralization, at least in vivo, was there. So what they concluded, these scientists concluded, was there was research to support that breastfeeding during mild to moderate maternal COVID-19 illness was actually beneficial. So, you know, this really was a pretty strong sweep, a pull away from the very beginning of the pandemic. So imagine what we were thinking February of 2020, where we had that reflex recommendation that if you were pregnant, you had your baby, 1, you're supposed to separate yourself from your baby. 2, you're not supposed to deliver breast milk to your baby. Now to a different setting, different situation where you have recommendation to actually not just not separate, but also literally breastfeed your baby, right? So we know that this breast milk was effective somehow in at least in vitro studies, and we know that it had the ability to show some type of positive effect similar to a passive vaccination. Now, for those of us who know a lot about breastfeeding, it's hardly a surprise because we know that for a variety of other viruses, RSV, for example, rotavirus, the flu virus, typical rhinovirus, for many viruses, there is absolutely good potential for breast milk to neutralize those antibodies. And that's why we always say, if mommy is sick, if she's well enough to breastfeed her baby, she should continue to breastfeed her baby in the setting of other illnesses outside of COVID. But now we have research to show that even in the setting of COVID, that there is good reason to do the same thing. So in May of 2021, the American Academy of Pediatrics, based on a lot of the research that I just discussed, modified their recommendation to limit separation and return to rooming in as a standard of care for most circumstances, with environmental precautions and engineering controls still being in place. And so those engineering controls would be things like hand washing, making sure that your equipment is clean as much as possible. If you are pumping, for example, making sure that you are masking as you are holding and caring for your baby or breastfeeding your baby. And direct breastfeeding is encouraged. Direct breastfeeding was encouraged because we not only know that direct breastfeeding is especially effective in terms of increasing the mother's milk supply quickly and allowing for the normative processes of breastfeeding to take place so that the complications of breastfeeding, such as excessive jaundice or excessive weight loss, don't take place. But there's also some research, which I didn't really include in this slide, but it's there, research that shows that COVID-19 has the ability to live on hard surfaces for longer periods of time. So plastic surfaces, metal surfaces, COVID-19 can potentially live on those surfaces for days. So if you're telling a mom to pump her breast milk, or a mom is thinking that if she pumps her breast milk because she's going to reduce her likelihood of passing COVID to her baby, she may actually be increasing the chances of passing COVID to her baby, because for as long as she's handling these plastic materials, if the plastic materials are living and if the COVID-19 virus is living and existing on these plastic materials, she can be passing COVID-19 to her baby by way of touching and handling these plastic materials if she isn't using adequate enough precautions to keep those surfaces clean. So direct breastfeeding is absolutely encouraged. And so this slide is essentially detailing what I had just discussed: washing your hands, wearing a mask, separation. You know, having a healthy caregiver or a caregiver who's well enough to care for the baby when the mom does not need to care for the baby, so she can recover herself from COVID-19, is encouraged. And isolation of not just the mother and baby dyad, but everyone who is in the mother-baby dyad circle. So not just mother-baby dyad, but mother-baby dyad and caregiver, grandmother, sister, whoever that happens to be, siblings, should isolate from all others until quarantine is fully completed for everyone. So moving on to COVID-19 breastfeeding and vaccination. Now, this is an area that requires a lot more research. However, we know that in May of 2021, 500 breast milk samples of 84 women who received 2 doses of the Pfizer vaccine was looked at. And the simple question was, does it work? It doesn't work. Does the vaccine actually work in the setting of breastfeeding? So what it found is that the secretion of SARS-specific IgA and IgG antibodies was found in the breast milk 6 weeks after vaccination. It found that IgA secretion was evident as early as 2 weeks after vaccination, followed by the spike in IgG 4 weeks after. And it found that, again, these antibodies were not just present, because what we want to know is not just, is the antibody present, but does it work? Is it actually doing its job? Yes, it was. Antibodies were found in the breast milk of women, and these antibodies had strong neutralizing effects, again in vitro, suggesting potential protective effects against infection and the illness. And so these tables are essentially showing these spikes that they're talking about here. So the left table with the black line is for IgA, the right table is for IgG, and you can see the time after first vaccination, there was a bit of a spike in IgA, not so much in IgG, but with the second vaccination, there definitely was an increase, a notable increase in both IgA and IgG, and these were working antibodies that were doing their job. And so what Pearl concluded from the study was the vaccine works. It increases antibodies in the serum of the mother. It increases antibodies in the breast milk of the mother, and these antibodies had neutralizing effects, with the practical conclusion being, if you have a mother who is breastfeeding, if she has not yet been vaccinated, she should get vaccinated, not just for her own protection, but for the protection of the baby. The COVID-19 vaccine is not available and is not authorized via EUA for newborns, and certainly not for infants. We just got down to 5 years old, but we don't have any approval to vaccinate less than 5 years old. So what's the next best thing a parent can do to protect that baby? She can breastfeed that baby, because breastfeeding in effect operates as a vaccine in this setting. It causes that spike that then gets passed on to the baby, and these antibodies have neutralizing abilities, which means that we can only assume that a similar thing will happen in the baby when that baby consumes breast milk. So another reason to not just encourage breastfeeding in the setting of COVID-19, not just encourage rooming in, but also encourage actual vaccination, because vaccination compared to native disease is significantly better in terms of producing this antibody response and the neutralizing response. So this particular study was it's probably, now that I'm thinking about it, December, right? Is probably printed, but at the time that I had put this slide in this presentation, it was pre-printed and not yet peer reviewed. It just went up online in October of 2021. And this particular study really was literally the most recent research that I was able to find on COVID-19 vaccination and breastfeeding. So this was a study that was published in the US. And what they did was they looked at, again, at vaccinated mothers against COVID-19 in the setting of breastfeeding. And what they found was that breast milk from 3 weeks after the second dose successfully blocked the ACE2 spike protein binding. And for those of us who have been looking at and talking about COVID-19 virus, we know that that spike protein is the thing. The vaccine prevents spike proteins from attaching to human cells and causing the destruction that it typically causes, that breast milk was able to successfully block that protein binding. And then 2 weeks after the second dose, of the 30 breast milk samples that they looked at, 26 of those had detectable levels of IgG antibodies specific for SARS-2. And all of the breast milk samples, this was really interesting, had cytokines. They had IL-2, 6, 8, 10, 13. 1 beta, INF gamma, and TNF alpha, and then the IFN gamma levels were significantly higher in breast milk after vaccination than before immunization. What does this all mean? We don't really know. They also found that more side effects to the vaccine were shown with mothers who had higher breast milk interferon gamma levels. What does this all mean? We don't really know, but we do know, right, that as for all viruses, the cytokine effect and the cytokine storm is a very significant part of the immune response, the human immune response to these viruses. So does that necessarily mean that this is essentially a demonstration of a robust immune response that breast milk is showing in response to vaccination? We don't really know. But this is really the first study of its kind that not just looked at the antibody, that not just looked at the neutralization effect, but also looked at the cytokine effect. So there is more research, obviously, that needs to come after this, but I just thought that that was interesting. So, and they found it and they published it. So we'll, you know, time will tell as to what really this means. And then in May of 2021, in a cohort of 100 women, of which 30 were pregnant and 30 were lactating, again, a lot of the same stuff. So, you know, the receptor binding domain, IgG and IgA antibodies in maternal serum, cord blood, and breast milk were higher in vaccinated women versus those who had the actual original infection, like I had just said. There was spike protein specific CD4 and CD8 responses found. So along both the T cell and B cell lines, there was a response that was noted. And what the authors concluded was the receipt of the vaccine was immunogenic in pregnant women, as well as in lactating women, and vaccine elicited antibodies were transported both to infant blood and breast milk. And so what this study did was it not only just contributed to the knowledge that we already had about the antibodies and the neutralization and all of that, but they attempted to show that there was actual transmissibility, right? So by looking at the cord blood in pregnant women and then looking at the breast milk and other lactating women, they were able to sort of demonstrate kind of that line between when the woman gets vaccinated and at what point that transmissibility occurs. So in addition to finding that there was potential for breast milk to offer that effective passive vaccination for the baby, they were able to also find that if a woman elects to vaccinate before she delivers, so while she's pregnant, essentially a similar effect occurs, that she's able to transmit those antibodies to the fetus, and that those antibodies had some type of an immunogenic response aside from just being there, but that they were able to also find that the B cell and T cell lines were lit up and responsive to vaccination even during pregnancy. The conclusion being that if you have a mother who has COVID-19 disease, who is well enough to breastfeed her baby, yes, she should breastfeed. But if you have a mother who has not yet had COVID-19 disease and who's getting vaccinated, yes, she should breastfeed. But if you also have a mother who is pregnant and has not yet had COVID-19, yes, she should get vaccinated. And yes, she should breastfeed, because all of this together really adds up in terms of how much immunoprotection you have to the baby. So imagine a scenario where you have a mother who is pregnant, who is set to deliver in the next couple of weeks, who chooses to get vaccinated, who's now passing on, after she gets vaccinated, passing on her antibodies to her fetus, and then she delivers that baby and then goes on to actually breastfeed that baby thereafter. You can really begin to visualize just how much immunogenicity that mother is providing for her baby by way of both getting vaccinated and by breastfeeding. And so, how do you protect these newborns? You protect a newborn by protecting the mother. Women who receive COVID-19 vaccine in pregnancy are able to produce that immunogenic response in themselves. They can pass it on to the baby, and they can pass it on through their breast milk with neutralizing effects, and with both the B cell lines and the T cell lines being responsive to the vaccine. And this is why all the major organizations, the ACOG, the AAP, the AAFM, that's family medicine, and the Academy of Breastfeeding Medicine, all recommend the COVID-19 for women, for all women, including pregnant women and including breastfeeding women. The ACOG also recommends a booster for all pregnant and high-risk women. This actually has changed, so everybody is recommending the booster for everybody now. And the CDC recommends boosters for all high-risk women with medical conditions. Again, that has changed. The CDC has now recommended the vaccination, the booster vaccine for everyone. But we can see why this is especially important for pregnant and for breastfeeding women. The more you have, the more you can produce this robust immunogenic response for the baby. So therefore, prevention really is the best medicine. And we know that breastfeeding is such a good thing because it is such a preventive breast medicine. But we now have the research to show exactly how it can be a good medicine in the setting of COVID-19 and in the setting of COVID-19 and vaccinations. So with all that good news, we can now sort of take it out and trickle it out into the community, and we can sort of be, you know, both breastfeeding and vaccinating champions. what really is happening out there? So there is not a lot of research that really talks about like how many pregnant women are getting vaccinated. You know, in the very beginning of the lecture, I just explained to you how many people are getting vaccinated, but we really don't have enough good information that talks about pregnant women getting vaccinated. All we have is really pretty much this. So this was some data that had come out in 2021. This was as of May of 2021. And it does show, unfortunately, just like how the general population has differences in their vaccination rates, pregnant populations have very similar rates. So you can see the very top sort of thicker dotted line represents the Asian non-Hispanic population, and the sort of dotted but with the two smaller dots in the middle all the way at the bottom represents the African American non-Hispanic population, with the other line that sits right on top of that representing the Hispanic population. And so what we see that when we look at pregnant women exclusively, Asian populations are more likely to get vaccinated. This particular study did not necessarily separate out Asian versus, like, say, Alaska Native, so that data just wasn't there here, but it did show that Asian populations are more likely to get vaccinated. African American non-Hispanic populations, followed by Hispanic and Latinx populations, are least likely to get vaccinated. And as of this research, this was May of 2021, only about 3% of African American women in the United States are vaccinated against COVID-19 in pregnancy. So when a mother is positive for COVID-19, one of the biggest questions we have is, when can I have visitors? Who's allowed to visit? Can my mom visit? All of these questions. And the information changes quite a bit, although there's like a couple of things that we know that are sort of definitely tried and trues, right? So if a mother is positive for COVID-19, when should she isolate and quarantine? If she has symptoms, she should isolate, she should quarantine. As soon as her symptoms resolve, she should get vaccinated. Now, the research still says, or I should say more like the recommendations still say, that you should vaccinate 3 months after you have had the disease, but much of the research really isn't supporting that, and a lot of physicians are now recommending that once a mother is well enough to be vaccinated, even if she has had COVID-19 and it's been less than 90 days, she really should just get vaccinated and just get it over with, because the more she can produce that immunogenicity, the better, especially if she's pregnant or if she's breastfeeding. So 10 to 14 days since symptoms have occurred, 24 hours with no fever, no antipyretics, and if all other symptoms are improving, then she can remove herself from isolation and quarantine. If she had just a positive test but wasn't vaccinated, she should still isolate herself for 10 to 14 days. And New Jersey does have a stipulation that depending on which county that you live on and depending on how prevalent the virus is in your county, you can potentially reduce that to 7 days, but you first need to look at the New Jersey Department of Health based on where you live to see if you can reduce it to 7 days. The healthy caregiver should be fully vaccinated and should be boosted. Should not really have any comorbidities if you can possibly pull that off. So you're looking for the healthiest possible caregiver that you have. Should, of course, use those engineering controls, hand sanitizer, all of that other stuff like we know about. Should minimize direct care to the newborn, unless the mother, except for situations in which the mother is not caring for the newborn. So with the goal being, you want to have that mother and baby stay together as much as possible. You want to facilitate breastfeeding as much as possible. Once that is done and the mother needs to rest, then the healthy caregiver jumps in. And should be prepared to isolate alongside the mother and quarantine from the community. So this is not going to be a situation where healthy caregiver is sort of going out to, dinner with friends when the mom doesn't need her, but really should be isolating just like how the mother is isolating in case the healthy caregiver acquires COVID-19 as she is caring for the mother-baby dyad. So this is a table just to sort of demonstrate that, and I'm not necessarily going to go through all of that, but I hope that if I'm allowed to share my slides with you, you can just sort of study it and then you can just kind of like apply your situation depending on what you have sitting in front of you. So this is a setting for like any kind of situation where the caregiver is not vaccinated. Of course, if the caregiver is positive and has symptoms, she should not care for the mother-baby dyad. If the mother is positive and doesn't have any symptoms, she should technically not care for the mother-baby dyad. But if there's nobody else available, she can care for the mother-baby dyad as long as she uses the appropriate engineering controls and quarantines alongside the mother. If she hasn't had any symptoms and has not been vaccinated, she should continue to use her engineering control. And then her isolation not only takes place at the same time as the mother-baby dyad, but should also continue for another 10 to 14 days after, because you want to assume, say in a situation where the caregiver develops disease or gets the infection, let's say on the last day of her period where she's spending time caring for the mother-baby dyad. If that takes place, then she will need to isolate and quarantine for its full 10 to 14 days. So, for example, if grandma is helping to care for the mother-baby dyad and she cares for the mother-baby dyad for 7 days and decides she's going to go home to her family after 7 days, she should isolate and quarantine for 10 to 14 days from the 7th day, another 10 to 14 days. So she's actually quarantining for 7 days and then another 10 to 14 days, right? Just to make sure that she is not passing the disease on to anybody else in case she gets the disease, let's say on the last day that she cared for the mother-baby dyad. This table, as this was as of November of 2021, shows some areas where there is activity level, and this is what I was talking about. You can find it on the New Jersey Department of Health. Depending on where you live, you may have moderate or you may have high activity. You can see, and this has been the case for quite some time, that Central and South Jersey, essentially where I am, Monmouth County, Ocean County, are the places that will tend to have the highest rates of infectivity. This changes very quickly and daily. And so from there, you can tell whether or not you need to sort of isolate for 10 days, if you need to isolate for 14 days, or if you can reduce it down to 7 days. If the caregiver is vaccinated, it's a lot easier. If the caregiver is vaccinated, essentially, that's the ideal situation. Like say, for example, if she's has a positive test, but she's fully vaccinated, she can actually safely care for the baby as long as she doesn't have any symptoms. But again, it's still the same thing. She should still continue to isolate or quarantine for 10 to 14 days. That can potentially go down depending on what the rates are in your community. It can go down to as low as 7 to 10 days. But what's important to remember is if you have no symptoms, you should test from the time of exposure, but you should also test again 3 to 5 days later, just in case it turns out to be that you may have been exposed and you are positive and you are in the process of turning seropositive and may have had a false negative. So this is especially true if you have like a caregiver that intends to go home to other family members that are either not vaccinated or have a lot of risk factors. You want to test yourself. You want to isolate, but you also want to test 3 to 5 days from the last time that you were caring for that mother-baby dyad, just to make sure that you remain negative. So now the last point that I just want to discuss here is maternal mental health in the COVID-19 pandemic. This is so important. We don't talk about it enough. This could be its own lecture, really. It should not be understated, the maternal impact of this pandemic, that how much it has had on the pandemic, on mothers who have already delivered. You know, we are the COVID-19 mothers and the COVID-19 babies, but how much it continues to have an impact on mothers who have had both COVID-19 and who have had to deliver during the pandemic. We are now in our 2nd year, right, of this pandemic. So we are starting to have mothers who had their first baby in this pandemic and who are now having their 2nd baby still in this pandemic, right? So the negative psychological impact on pregnant and postpartum mothers is significant. They are more likely to show signs of depression, and they are more likely to also show signs of anxiety. The key themes is that they feel a lack of support from family members, from friends and providers. They are oftentimes not allowed to have the visitors they want to have. They may not feel comfortable, or a caregiver may not feel comfortable visiting for some time. They may not feel comfortable leaving the house to visit the baby. Mothers may feel isolated. There is really no mothers groups that are happening the way that they used to happen. So mom groups have been transferred over to Zoom, which is not the same as being able to see somebody face to face. And so there's certainly a lot of anxiety that's taking place. And especially like with this new variant coming out, there's a lot of anxiety about, well, what's going to happen in the future? How long is this going to go on for? And what will be the impact on my baby? Many mothers stopped breastfeeding way earlier than planned, which is unfortunately not a surprise. But many still felt like breastfeeding was important. So 64% of them had planned to breastfeed according to the study in 2021, but did not. So 64% had planned on breastfeeding longer, but did not. Interestingly, the opposite was true for some moms. Up to 20% of them breastfed longer, in part because they were home, they were working from home, they may have lost their job. For example, they didn't have as many visitors, so there was just simply more opportunities to breastfeed. Black mothers were more likely to express a lack of social support, however, in this setting. But paradoxically, 80% of them were not worried about the risk of breastfeeding during COVID, even from the very beginning of the pandemic, which is interesting. So while many medical providers were really worried about possibility of COVID-19 transmissibility in breast milk, many parents were not. But they still stopped breastfeeding if they were told by their providers or their family members not to do so. Mothers feel strongly that breastfeeding is important, even though they're ill with COVID, but anxiety was focused less so on the possibility of passing COVID to their baby, but on the need to care for other children and on decreased access to lactation care. So this study was done in 4,000 mothers in the UK. And what they found in this qualitative study was that anxiety increased if there was more than one child in the home. How am I going to take care of all these children if my mom can't come to help me, or if my sister doesn't feel comfortable coming over, or if my brother who normally helps me is ill and doesn't want to be around or doesn't want to go outside. All forms of breastfeeding advice and support decreased during the pandemic. So again, like I said, the mothers groups went down, access to lactation care went down, home visits went down, and this carried a significant impact. And it was really interesting to note in this study that of all the things that mothers could express anxiety and worry during the pandemic, lactation was really at the top of the list, right? In addition to caring for other children. And this is important to note. And then the psychological maternal impact on COVID-19 in the setting of COVID-19 and breastfeeding. Again, we see that for mothers who exclusively breastfed compared to mothers who exclusively formula fed, while all of them expressed some level of anxiety, it was notably higher in mothers who exclusively formula fed, really again pointing to not just the medical benefits of breastfeeding in the setting of COVID-19 and breastfeeding, but also the psychological benefits of breastfeeding in the setting of COVID-19. So in this particular study that came out of Italy, they were able to show, looking at 160 women, that mothers who exclusively breastfed still had higher anxiety with COVID-19 during the pandemic compared to pre-pandemic times, but overall it was much lower, as you can see in the rectangles all the way over to the left, compared to the formula feeding moms, for which anxiety was not only higher during pre-pandemic times, but significantly went up in post-pandemic times and current times. Again, another case for breastfeeding, showing that breastfeeding really does go beyond just the medical benefits, but really has good psychological protective effects. And again, we can't really emphasize this enough, because, you know, for someone who has not delivered her babies, thank God, during this COVID-19 pandemic, I can just imagine just how stressful it is when you are delivering your baby and starting your family in the midst of all this craziness. Anything you can do to protect yourself against the psychological impact, you want to do. And so it's really important as providers to make sure that we impress this upon our patients. So to go back to the study, JS was only 19 years old. Right? She presented for a telemedicine visit. She had lactation problems. She was diagnosed with an abscess, mastitis. She was later diagnosed with an abscess. There were a lot of things that we now can consider that maybe we really didn't think about before. She was only 19. We found out later on that she was unemployed, that her husband was the sole provider for the family. So these were not people that had a lot of financial resources. Breastfeeding was important to them for financial reasons. The main reason why this woman wanted to breastfeed and why she was reluctant to stop was because she was worried that she would not be able to afford buying formula. She denied fever, but she did not have a thermometer at home. Very, very common. A lot of people say they don't have fever, but they don't think to take their temperature, right? Especially a 19-year-old didn't think to necessarily take her temperature. So it's important that we continue to provide face-to-face access for these patients as much as possible and not overly rely on telemedicine. We did telemedicine in March of 2020 because we had to. Like we literally did. We were told we were not allowed to see patients face-to-face at our Center for Breastfeeding. But now that we have options, whenever you can, it really is a good idea to try to see these patients face-to-face with good engineering controls as much as you possibly can, because things like this can happen where they may not have a fever, they said, but when you go in and you take their vitals, they really do have a fever. So like I said, the husband was a full-time working man. He had no paternal leave. She was home alone. Her family members were not allowed to visit her because we were all under quarantine. So she really, truly was literally alone at home. When the mother went to the ER, it was the first time in 3 weeks she was seen by any provider. She was declined a face-to-face visit by her pediatrician. She was actually also declined a face-to-face visit by her OB as well. So this was the first time she had been seen by any provider, and here she is in the emergency room, and she has to be hospitalized and she has to have surgery. It was quite a stress for her. Recommendations to stop breastfeeding did not include the long-term wishes for the mother, and this mother did express her concerns about financial difficulties and financial hardships, but this did not sway the hospital staff to still recommend stopping breastfeeding, which is unfortunate. The fear was still, could she pass COVID to her baby? Should she be breastfeeding in the setting of a pandemic? What do we do? But even now, even though we know all of this information, we know that this still continues to exist in ERs where patients are told to just stop breastfeeding without any consideration for what the long-term impact is going to be, not just medically on the mother, not just medically on the baby, but also other reasons, psychological reasons, emotional reasons, and financial reasons. So how would we approach this case differently today is what I'm going to leave you guys with, something to really consider and something that I would encourage you guys to see how you could apply this practically to your day-to-day care, and how you could potentially prevent cases like this from happening going forward as we continue through this pandemic. So COVID-19 affected mothers are firstly affected with higher burden of disease compared to non-COVID mothers. Vaccination during pregnancy and breastfeeding show immunogenicity in both the mother, not both, in the mother, the cord blood, and the breast milk, threefold. COVID-19 pandemic has caused significant mental health morbidity, but many mothers continue to say that they feel like breastfeeding is worth the effort, even in the setting of pandemic. So it's important that we provide that support as much as we can provide that support and as safely as we can provide that support. Providers are encouraged to create a care plan which includes a responsive and meaningful discussion on vaccination during pregnancy and lactation and supporting mothers who desire breastfeeding. And this is all I have for you, and I thank you so much for your time. And if I went over, I apologize.
Thank you.
And I am happy to take any questions.
Great. Well, thank you so much. You gave so much information, and I really appreciated hearing how we evolved in our knowledge throughout the past year and a half, almost two. We did go over time, but if you can take a moment, and for those who are able to stay on, I'd just like to squeeze in a question or two if I can. How can we encourage OBGYNs to have a stronger recommendation for vaccination to patients during pregnancy? Many seem to not want to push their patients or even educate on the importance of vaccination during pregnancy.
Yes, this is absolutely true. You know, with the theory being, like everybody else, we need more information. We don't really know. We just want to make sure that the fetus is safe and that the pregnant mother is safe. Well, I would encourage OBs to remember that we already have the research. We have the research that shows overwhelmingly that the vaccine is quite well tolerated in the general population. So we have that. Next, we have good research that shows that it is also overwhelmingly well tolerated in pregnant women with no known adverse effects to the fetus that we know of and are aware of. And we know that the detrimental impact of COVID-19 disease in the baby, in the mother and in the fetus in some cases, when the mother gets the native disease. So the research is there, and I think we can say it's time to stop that discussion about we don't know enough. I think that OBGYNs need to be empowered to really encourage that, to really encourage it from a public health perspective, and to really learn how to have that conversation about the positive impact, not just for mother, but also for her fetus, and for the baby. Really just empower them to make sure that they know how to have those kinds of conversations and not feel like they're sort of imposing or pushing on the mom.
Right. Okay. Thank you. And one quick last question. Is there a preferable time during pregnancy to receive a vaccination, booster or otherwise?
That's an excellent question. We don't really know exactly if there is an ideal time. I have to say that much of the research that I presented did show that many of those moms got vaccinated in the 3rd trimester. And so when we're talking about transmission through the cord blood, many of these moms were vaccinated not too long before they delivered. So somewhere in the range of 4 to 6 weeks, 4 to 8 weeks or so before they delivered. And so based on that information, some OBGYNs are saying that if you can vaccinate yourself in the 3rd trimester, that is preferred for 2 reasons. One, the fetus is more or less fully grown and fully developed, or at least kind of the important stuff is kind of set and in place, sort of is the idea. And so, you know, even if the mother, say, delivers prematurely and we don't know why, and there's speculation as to whether it's from the COVID vaccine, the outcome to the baby is significantly higher, but also because the research looks mostly at 3rd trimester moms. And so that's why that sort of anecdotally, that research is there, but really kind of looking at what the real research is showing across all 3 trimesters, we really don't know if there is an ideal time to vaccinate or if there is a time where we should avoid vaccination. There just isn't enough research to show either way.
Okay, great, thank you. Well, it seems like we may have to have you back as we get more and more information all the time. So thank you so much, Dr. Fleur. And thank you for everyone for staying. We've got a lot of positive comments coming in the chat box. So I just want to remind everyone that you will receive a link to post-program evaluation. Your feedback is important, so please take the time to complete, and certificates of completion will be sent via email within about 1 week. And a calendar of the partnership's upcoming virtual programs can be found at www.pmch.org under the Professional Education tab. On January 20th, Dr. Judy Levison will present a webinar titled Breastfeeding Among Individuals Living with HIV, a reasonable or an unreasonable option. We also offer on-demand recordings of many of our programs, as well as abbreviated 15 minutes or less educational videos, all of which are listed on our website. So thank you. And any other last words, Dr. St. Fleur?
Please encourage your patients to get vaccinated. Please get vaccinated.
Well, thank you for all the information to be able to support that.
Have a great and safe holiday. Yes, thank you so much.
Thank you. So, and thank you for everyone who joined us today, and I hope you can join us for future educational events.
Thank you very, very much. Thank you for having me.
My pleasure.
Bye-bye.